I'm Lori Berard, and I'm here with Dr. Pratik Choudhary, who is from the King's College Hospital in London, UK. And we've been having a great conversation about diabetes and technology. And so we recognize that people that are using technology such as insulin pumps and continuous glucose monitoring systems are going to come to hospital for pre-planned procedures. So what do we need to think about in terms of, let's talk, that they come in for a MRI or a CT scan. Is there anything specific that we should know about that?
So yeah, I think a lot of people have to have these investigations as part of their care. And of course, with an MRI, it's pretty straightforward. Anything metallic doesn't go anywhere near the machine, and you'll have a radiographer who will check the patient to make sure. So for people using continuous glucose monitoring systems, of course, these are the devices attached to the body. They're going to have to take them off and leave them outside. No.
Yes, but what about the one that's actually under the skin? Like, what happens? So we have a couple sensors that sit on the outside of the skin, and so unfortunately, when you do take those off, that needs it's a new sensor. So it'd be nice if you could plan to have those procedure at the end of the life cycle of that sensor.
Or what a lot of patients do is they plan it so if they know they're going to need a procedure rather than, and it's going to be on day 3 of when they would have it, they just delay putting a sensor in, and for those 3 or 4 days they might just use their finger pricks so they can come home and then put it in.
But if they come in with one on the outside, it's pulled out.
It's got to go. And then with the implantable sensor, this is a device called the Eversense, and this is implanted just under the skin into the subcutaneous tissue. Now, as it stands at the moment, those devices need to come out, and so that's a procedure where you have to basically take it out. It's a bit like an implantable
for the MRI.
For the MRI.
And what about CT?
And so for CTs, there's a less clear advice on there. Of course, if the device
for all of the devices.
For all the devices, for the CT, if the CT is in the line of fire, if you like, then of course it's going to have to come off. For a CT, for a continuous glucose monitoring, a device that's on the arm, if you're having a CT of the chest or stomach, the suggestion is that the radiation can affect the electronics, might affect the glucose readings temporarily. So I think there's a caution note there. But
so increase your capillary glucose monitoring after, just to make sure.
Double check to make sure it's accurate, but on the whole, we think it's safe. Of course, the advice would have to be check up with the manufacturer of your device. There's so many new devices coming out.
The labels change.
And the labels change and the advice changes. But our experience has been for CT scanning, sensors are generally okay.
So really great information about continuous glucose monitoring systems and MRI and CT. Pumps, is there consideration around insulin pumps in those situations?
Yeah, so I think the same thing holds. So again, a pump, you can't take it into an MRI unit, and so you'll have to disconnect the pump. Important to make sure you put it in a safe place, because you want to get that pump back when you come out of your MRI. And I'd say take out your cannula, take out everything out and leave it there. So an MRI scan is going to last for an hour. So what we generally advise people is measure your glucose, take whatever action you need to take, correction or whatever, and then as soon as you come back out of the MRI scan, measure your glucose again and correct and manage. And for an hour without insulin, you're generally okay.
If the cannula is not steel, do they need to remove it because the plastic cannula?
A lot of them are plastic. So they can stay in if you need to be. If it's not for steel cannula, make sure you take it out.
Yeah. I mean, if someone came in and they didn't happen to have a spare cannula, but a steel one for sure should come out because of the and anything about CT?
So CT, although on a lot of the manufacturers' websites, they will have a caution around CT, but actually most of the international guidance says that for CT you're okay. The main concern is if the pump device is in the line of fire of the CT, then the radiation can have an effect on the electronics theoretically. And if there's concerns, actually, again, CT scans are generally quite quick 20, 30 minutes, a minute, 5 minutes, often very short. And if you're concerned, just disconnect, have your scan, and reconnect in, and that's pretty straightforward.
So now, what about the person who's coming in, let's say for an endoscopy? So something that's relatively short, less than 2 hours, but they are going to, be anesthetized and have a nice little sleep during that. Anything about that?
So our rule of thumb would be for a procedure that's less than 2 hours, most people would be okay to be on their pump or continuous glucose monitor during that. Of course, things you have to be aware of, because you'll be siting your pump or your CGM in the week prior to your procedure. You need to make sure that it's away from an area that might be used for that procedure. And of course, if there's any concern or doubt, for things like an insulin pump, you can easily disconnect your pump for a couple of hours without any particular harm, as long as your glucose is relatively stable when you go in. And we have some guidelines, there's lots of published guidelines out there, but roughly speaking, if the person measures their glucose and does a correction an hour or so before the procedure, then even if they disconnect, they're going to be okay. And then when they come back out of the procedure and they wake up, they can then measure their glucose again and make whatever therapy is needed. And for anything under 2 hours, that should work. So for things like endoscopies or arthroscopies or any even small surgical procedure that's less than 2 hours, that should be okay.
So would it be safe to say for individuals having a pre-planned short surgery that they've often checked back with you, their diabetologist or their diabetes nurse specialist or whoever is really helping them manage their technology and their diabetes to make sure that they know what they're doing when they come in, that we're not expecting that person doing this procedure right then and there to make a decision as they might in an acute situation to make a decision about that because that consultation hasn't occurred. But typically they've got some supports out there that they can go back and say, hey, this is what's going to happen, how should I manage it? Because they're going to come in knowing more about their technologies, especially with their pump, than perhaps the person who's doing the procedure. So confidence that they're coming in saying, no, this is what Dr. Choudhary told me I should do when I come in, and so this is what we're going to do, but please check my blood sugar while I'm sleeping, either on my continuous glucose monitoring system, here's how that works, or by all means poke my finger for a typical capillary glucose, or send it to the lab, whatever works, right?
So I think a useful tip for our listeners would be, if you've got someone and in your pre-assessment you've worked out they have diabetes, if you ask them how do they manage their diabetes, and if it comes up with a continuous monitor or a pump, then if they've got a monitor, that's great, because that means that during the procedure you can check their glucose, and you can be aware of what's going on, and if they have alarm set. And if they're on a pump, it's quite simple to say, if they're under 2 hours, then you can say, don't need to worry about it, you do what you need to do, and it should be fine.
Because they're waking up in 2 hours.
Of course they're waking up.
But there's other procedures that they may not be awake in, like something like a knee replacement or a hip replacement, pre-planned for a long time, a lengthy procedure for someone. And obviously one of the keys about allowing them to use their technology is that they are the ones comfortable with it. So what about for individuals with longer procedures?
So, and I will take this, in two ways if you like. Our cutoff generally, most of the guidelines is about 2 hours. And so if you've got a longer procedure, any major surgery, then the safest thing to do in that scenario is you've got an anaesthetist there who's going to be monitoring the vitals, and they can, anything like that in pre-op, you want to be taking the pump away. The key thing actually is to remember not to forget to know where that pump is kept and have it safely stored. We've had a few pumps go walkabout and get lost in recovery or somewhere, and those are expensive pieces of kit. But convert onto an intravenous insulin, and then the anaesthetist knows what he's doing. He knows what the glucose is.
He's been doing that for a long time, with or without the person having been on, he or she, with or without that person having been on technology, it doesn't change, right?
No, it's exactly the same, and then you know where you are. The advantage is if they've got a continuous glucose monitor, then they can have a discussion with their anaesthetist, and if the patient cites it somewhere that's not going to interfere with the field of surgery, then we've had a lot of reports of anaesthetists saying, actually that's quite handy, that I can look at the monitor and use that, and instead of having to prick the finger every 30 minutes or hour during the operation, I can use that to guide what I need to do, and if I need to make an action. So it can be useful. With CGM, there is some advice around diathermy. So if the procedure is going to use dual bimodal diathermy, then that can affect the CGM device, and it can have a impact on it. And so you want to be asking, is the surgeon going to be using diathermy? Most manufacturers advise against using CGM or having a pump on if the patient is using diathermy. Now, there's
probably because they've never really studied it, so it's better safe than sorry.
There's theoretical reasons why the magnetic waves around the diathermy can interfere with the sensor glucose readings of the pump. So there is a caution around it. Now, of course, if you have a look, there's lots of people who've had procedures with diathermy where it hasn't been a problem, but there is a caution, and then I think that's between the clinician involved. You look at the manufacturer's recommendations and see what you want to do, but I think most anaesthetists find it quite handy if their patient has a CGM to be able to use that to monitor the glucose rather than all the time, rather than have to prick the finger intermittently. But so rules of thumbs are, I guess, if it's a long procedure, make sure the pump is off and stored in a safe place. And you're on an intravenous insulin infusion for that. And with CGM, you can make a decision if it's sited in the right place, there's no diathermy, then it's quite a handy thing to keep going during the operation.
And remember that once that person is post-operative and able to self-manage, that it's a great opportunity to start transitioning back onto the technology that they've been using to manage their disease, as long as they're able to.
And a bit like with injections, as soon as that person is, generally a key factor is eating and drinking, then you can put them back on. And that person will generally know what to do. A useful tip is that when you put the pump back on again, if the patient can have something to eat and take a bolus for it, then the insulin is there straight away. And we say the same for people on injections. Make sure you give them something to eat, and you can take a bit of quick acting insulin there, so that gets the insulin levels up and running straight away, and then leave the intravenous insulin on for about half an hour to an hour, so there's that overlap. And so those things stand even with a pump, just as they would with injections.
And you've mentioned a few times guidelines. Is there any particular guidelines that would be helpful for people watching this that they could reference in terms of this type of management?
So there's a bunch of guidelines out on the internet. Certainly based in the UK, we've put together through the Diabetes Technology Network some guidelines for pump therapy in hospital in particular, and those are freely available for people to download, and I think they're going to be linked onto this conversation.
And I'm Canadian. We happen to have some in our clinical practice guidelines as well in terms of in-hospital management. Thank you very much.